Okay, this chapter is talking about pain, which is the body's warning mechanism. And pain is difficult to define, and of course, it's highly subjective. But we had already said it's a warning mechanism, a defensive property indicating that there is a problem, particularly when it is acute. Pain may be felt because of inflammation, infection, ischemia, tissue necrosis, stretching of tissue, chemicals, or burns. Now, skeletal muscle pain may be caused from ischemia or hemorrhage. In the viscera, abdominal organs, there are pain receptors in the covering capsule. Pain is felt when inflammation occurs, so in various organs like the liver, the kidney, or the brain. In the stomach and intestines, pain may result from inflammation of the mucosa or from distension or muscle spasms. So pain receptors are referred to as nociceptors. These are free sensory nerve endings that are present in most tissues of the body. They may be stimulated by thermochemical or physical means. And here's the pathway. It starts with a stimulus, and then you stimulate a nociceptor, pain receptor. Then it goes to a peripheral nerve, which is the afferent pain receptor, which is sensory. And then you go to the synapse, which occurs in the spinal cord, and then you get spinal decussation, which means it crosses over to the other side. And then by way of a lateral spinothalamic tract, which is a pain receptive tract, you go up through the reticular formation in the pons and the medulla, that's awareness of pain, and then into the thalamus, which is your sensory relay station, which takes the information to the somatosensory cortex in the parietal lobe, which locates the origin of the pain, and then to the hypothalamus, which initiates the stress response, and the limbic system, which is attached to the emotional response. So that's the pain pathway. Now, this is the theory of pain and pain control. The key to blocking the transmission of pain impulses to the brain is the release of opioids. These are morphine-like substances secreted by interneurons in the central nervous system. They're called endorphins. Now, there are others. There's dynorphins, and enkephalins are the main ones, though. They increase the threshold for pain. They block pain receptors by binding to opiate receptors. And this can explain withdrawal symptoms found after opiate addiction due to when you're in the addictive process, you stop producing enkephalins during that time. So it's kind of like this rebound effect, not having enough enkephalins to suppress the pain response during withdrawal. So here it's showing you, in the top picture, it's showing you what happens by stimulating this pathway and the release of substance P, and substance P completes the pathway to cause the pain response. But down here with the presence of enkephalins, they block the opiate receptors and they block the transmission from the primary nerve in the pathway. So it stops the transmission of that pain response. So that's how enkephalins work. And this is, again, it's a theory. So the characteristics of pain, let's assess the severity. So the localization of pain is the first thing, and sometimes it's not specific due to referred pain and reference to various dermatomes. And we'll talk about referred pain in a few minutes. Descriptive terms can be used. Pain can be aching, burning, it can be sharp, throbbing, widespread, cramping, constant, periodic, unbearable, and moderate. Those are some descriptive terms used to define types of pain. Timing of pain or association with food intake, movement, or pressure applied to the site. It only hurts me when I move. It only hurts me when I breathe. These types of things. Evidence, physical evidence of pain. Stress response, such as pallor, sweating, high blood pressure, or tachycardia. Nausea and vomiting or fainting and dizziness sometimes happens with acute pain. Anxiety and fear. And this is experienced many times with chest pain. It's sort of that impending doom. Clenched fists or rigid faces. Restless or constant motion or immobilization. Now, referred pain, this relates to the fact that there are multiple sensory fibers from different sources connecting to a single level of the spinal cord, and this makes it difficult for the brain to discern the actual origin of the pain. And the perception of pain that occurs at a sight distance from the source is what we refer to as referred pain. Generalized and referred pain are characteristics of visceral damage in the abdominal organs. For example, pain in the left neck and arm is characteristic of heart attack. So the top picture gives you some referred pain sites. And I mentioned dermatomes. Dermatomes are regions of the skin that are innervated by a branch of a particular spinal nerve. So if a spinal nerve is involved with connecting to a particular visceral organ, it also has a location that attaches to areas on the skin, and that could be far away from where that visceral organ is. And that's where you get these different sensations being experienced. So, there's something else here that's called phantom pain. And phantom pain is pain or other sensations such as itching or tingling following an amputation. It's not fully understood, but apparently the brain still understands that the limb is present when processing the incoming stimuli. And also keep in mind that pain reception as a whole and the response are subjective to a large extent and depend on the conditioning of the individual. And you probably already know that pain is usually rated on a scale of 1 to 10, where 10 is the most severe. So speaking to acute pain is defined as something that's sudden and severe but short term. It indicates tissue damage and decreases once the cause has been treated. It may be localized and generalized. It usually indicates a physiologic stress response with increased blood pressure and heart rate, cool, pale, moist skin, increased respiratory rate, and increased skeletal muscle tension. Vomiting may occur. Also, may be strong emotional responses, body language, and high anxiety level. Chronic pain is more difficult to treat effectively. It's long-term, and it tends to last a much longer time. The outcome is less hopeful. The specific cause is less apparent to the person expressing the pain. The pain is more difficult to deal with and can be quite debilitating at times. Over long periods, the individual is frequently fatigued, irritable, and depressed. Sleep disturbances are common, and appetite may be affected. Chronic pain is often perceived by the patient as being more generalized. Constant pain affects daily activities and may become a primary focus of the individual. It can complicate measures to affect pain control by meds or other methods. Periods of acute pain may add to the distress of the patient. Long-term pain usually reduces tolerance to any additional injury or illness. Headaches. There are many types and causes of headaches. Headaches associated with sinus problems. So congested sinuses, nasal congestion, and eye strain are located in the eye and forehead areas. Sinus headaches can be quite severe. These headaches are usually steady and relieved when the cause is removed. Tension headaches are associated with muscle spasms resulting from emotional stress, and these tend to persist for days or weeks, and they tend to occur in the occipital region. Headaches in the temporal area, often associated with TMJ syndrome, temporomandibular joint syndrome, could be caused by malocclusion involving the jaw or inflammation of the joint as seen in arthritis. Migraine headaches related to abnormal changes in blood flow and metabolism in the brain. These aren't really fully understood. Precipitating factors, though, atmospheric change, stress, menstruation, and hunger. Pain is throbbing and severe, and it can be incapacitating. In many cases, there is a prodromal period with an aura or brief hallucinations or possibly nausea followed by the headache. Can be accompanied by visual disturbances and dizziness, nausea, and abdominal discomfort and fatigue. These can last up to 24 hours, and I'll tell you what, they can last longer than that, sometimes for days. Treatment is difficult, but Imitrex or ergotamine may be effective if administered immediately after the onset of the headache. The earlier, the better. Intracranial headaches. Increased pressure inside the head. Causes of increased pressure include trauma with edema or hemorrhage, tumors, infections such as meningitis, or inflammation resulting from toxins such as alcohol. These are pain control methods for managing pain. So this table looks at mild pain, moderate pain, and severe pain, looking at some of the commonly used substances, what it acts on, and some of the adverse effects. So you can look that over. Other pain control methods, sedatives, which have a calming effect. Anti-anxiety medications like lorazepam or Valium. Patient-controlled analgesics. Small pumps attached to vascular access sites. These are regulated by the patient, administered when needed. Intractable pain, meds don't help. Surgical intervention is the only choice. And I skipped alternative therapies, but there are a whole bunch of these. Massage, acupuncture, many others, natural alternatives. Now, if the pain cannot be treated effectively by medications or any of the other above methods, rhizotomy is a way of severing the sensory nerve pathway in the spinal nerve, may be required. So you can actually block the nerve if that's the only way you can treat the problem. These are anesthetics, local, general, spinal anesthetics, some of the common ones, what the effects are, and the purpose, and I will let you look that over as well.